Hereby, I open this academic ceremony in which Mark Keulen will defend the academic thesis Outpatient Hip and Knee Arthroplasty, Advancing the Optimization of Care Pathways. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Pro-Rector, thank you for the introduction. Dear members of the Corona, dear promotion committee, dear family, friends, colleagues, and those watching online. Over the next 15 minutes, I will present the key findings of my PhD thesis entitled Outpatient Hip and Knee Arthroplasty, Advancing the Optimization of Care Pathways. Let me first start by outlining today's presentation. The first part is a short background to explain what hip and knee osteoarthritis is, how we treat it with joint replacement, and how recovery after surgery has changed over time. From staying in the hospital for a while, which is called inpatient recovery, to even the possibility of going home the same day, which is called outpatient recovery. This brings us to the main focus of today's presentation, outpatient joint replacement, which I'll discuss from 3 different perspectives. First, I'll discuss from the healthcare perspective, then the surgeon's perspective, and finally, the patient's perspective. Here you see 2 healthy joints, the hip at the top and the knee at the bottom. The blue part is the cartilage, which lets the bones move smoothly without any pain. In the next picture, you see what happens with osteoarthritis, also called arthrose in Dutch. The cartilage wears down, the bones rub together, and that causes pain and stiffness. When the pain becomes too much, we can replace that joint with an artificial one, like in the last pictures. And if only one side of the knee is worn, we can sometimes replace just that part, called partial knee replacements. Usually, patients stay in the hospital for a while to recover after surgery and make sure everything is fine. This is called inpatient recovery. And in the past, this usually lasted about 2 to 3 weeks. But care has improved a lot, with better pain control, faster mobilization, and smoother logistics of the pathway. As a result, patients recover faster, have fewer complications, and can now go home after just 2 or 3 days. As an example, here you see data from colleagues in Denmark, and over the years, the length of stay of these surgeries has dropped from 4 days length of stay in the hospital in 2010 to 2 days in 2020. This made us wonder, if patients recover this quickly, could these surgeries even be done as a day procedure? In other words, could patients go home the same day after surgery, called outpatient recovery? After surgery, all patients can have some pain, swelling, might feel nauseous or anxious, and that's completely normal. Sometimes, maybe even a complication might occur. The big difference for outpatients is time in the hospital. They go home the same day, so they have less time in the hospital to experience all these ups and downs. And us doctors, but also nurses, physical therapists, also have less time to reassure the patient that everything is okay. And that's why the selection of these patients, but also clear education and setting realistic expectations is so important. Now we will focus a little bit more on the healthcare perspective. We looked at what is already known about it and what are their own experiences with it. We looked at 41 previous studies comparing outpatient and inpatient hip and knee replacements. And for our work, we considered a true outpatient as someone who goes home safely the same day as surgery. Some studies were less strict and included patients who went home the next day. Using our definition, only 25 out of 41 studies really counted as true outpatients. This table shows the key findings from these studies. As 92% of patients were safely sent home on the same day as surgery, showing it is possible. For patients who underwent a hip replacement and went home the same day, the chance of a complication was about 45% lower compared to those who stayed in the hospital. And no differences were seen for serious complications, readmissions to the hospital, and functional recovery. On average, however, outpatient pathways saved about $6,800 per patient. So this indicates that going home on the same day as surgery is both possible and safe, provided it is done for the right group of patients. However, in these studies, the outpatients were generally younger, had lower body weight, and had fewer or milder health problems. Let's now look at our own experiences with outpatient joint replacement. We first started this in 2013, and at that time it was only offered to selected patients. Until 2019, we performed about 525 outpatient surgeries and decided to look back at the results. We studied several outcomes to see how safe and successful it was. About 4 in 5 patients were able to go home the same day, whereas 1 in 5 had to stay longer in the hospital. We found that patients who had a total knee replacement were more likely, about 1 in 4, to need a longer stay after surgery. For partial knee replacements, this was significantly lower, about 1 in 7. Some patients stayed a bit longer, mainly because of symptoms like the pain, the nausea or fear, things that made it harder for them to recover and feel ready to go home. The most common issue, however, was that the leg felt weak or numb after surgery, which made it hard for these patients to start exercising right away. And this occurred about 10 times more often in the total knee replacement group compared to the patients in the partial knee replacement group. We think this is because during total knee replacement, the surgeon injects a pain medication on both sides of the knee. And this might temporarily affect the nerve on the outside of the knee. For partial knee replacements, this was less common, since the injection is only given on the inside of the knee. And that's the place where that specific nerve does not run. We also looked at which patients were more likely to go home the same day. Patients who had surgery before on the other leg were more likely to go home, probably because they already knew what to expect from their previous surgery. Those less likely to go home were women, patients having a total knee replacement, and those who with more or more serious health problems. Looking at the overall complication rate, we found a rate of 15% of patients that had a complication. On the bottom of this figure, you see the number of days after surgery, and on the side, you see how many patients had a complication. There was no differences between people who went home the same day, that's the blue line, and those who stayed overnight, the red line. Most issues, however, happened in the first few days, and those were minor and only needed observation. The most common complications included that the surgical wound was not dry, patients had too much pain, or had trouble emptying the bladder. Importantly, there were no serious medical complications like a heart attack, blood clot, or stroke. Overall, about 4% of patients had to be readmitted to the hospital. Again, there was no difference between patients going home the same day and those staying at least one night. Most readmissions also happened in the first few days after surgery. And the most common reasons were, again, that the surgical wound was not dry and that the patient was in too much pain. Next, we look at the surgeon's perspective. And we wanted to know how often is this used in the Netherlands by Dutch orthopedic surgeons, and what is the current outpatient and inpatient pathways, how do they look like? We did a survey among Dutch orthopedic surgeons, and about 1 in 5 currently performed outpatient surgery. The most common reasons to perform it were that they saw like a gradual decline of the stay and like their positive experiences with the outpatient surgery, but also the growing evidence that it is safe and it is feasible, but also patients requesting it. At last, surgeons reported that they also wanted to reduce the overall healthcare cost. For those surgeons who don't currently perform outpatient joint replacement, about half said that they would be interested in doing it in the future. The main reasons for not performing it yet was that they were not convinced by the evidence, logistical issues, patients that are not suitable for the outpatient pathway, and the current payment for the treatment by the insurance company. In the same survey, we compared outpatient and inpatient pathways and found a few medical differences. For example, patients in outpatient pathways were more often received 2 doses of a specific medication, which helped to reduce blood loss during surgery. Whereas in the inpatient pathways, usually only 1 dose was given. Other differences were mainly because of logistics, which is optimized in the outpatient pathway to ensure that same-day discharge is feasible. Finally, we looked at the patient's perspective, and we interviewed 12 patients and their caregivers with a family member to find out how they experienced the outpatient pathway. Of the 12 patients, we interviewed 9 patients who had a total hip replacement and 3 had a total knee replacement. And we asked about their experiences in different stages: before surgery, the day of surgery, recovery at home, and also the overall experience with it. We observed that patients chose outpatient surgery for several reasons. It was recommended by their surgeon. The patients felt fit and healthy, they had a caregiver available at home, and they liked the comfort and privacy of recovering at home. Patients were satisfied with how the day evolved, but to make the experience even better, we should focus on better education, setting realistic expectations, but also reducing the overall burden by improving logistics for the patient and their caregiver. On the day of surgery, 10 of 12 patients were able to go home on the day of surgery, and only 1 patient reported some fear of going home. At home, most felt that recovery was comfortable and manageable, and only a few contacted healthcare providers because of an event or because they felt uncertain and just wanted to speak to a healthcare professional. However, they reported that they would not have been better off in the hospital during those events. One caregiver was a bit worried about the pain and felt uncomfortable with the care she had to provide for her husband. Overall, patients were very satisfied with outpatient surgery. About 92% preferred going home the same day, and all patients said they would recommend it to others. So, to wrap things up, this procedure is safe and effective for the right patient. Not everyone can go home the same day, so we always need a backup plan. We need to keep patients in the hospital only as long as necessary by asking, why is the patient still in the hospital today? In the Netherlands, the complications are usually minor and observation is usually enough. And in the Netherlands, it is not used as much as it could be, mostly because of logistical and organizational issues. But where it is used, patients are very satisfied, and I would like to do it again if necessary. And with this, I want to thank all of you for your attention, and I want to give the word back to the Pro-Rector.
Thank you very much for your clear presentation. It's now time to start with the opposition. And the opposition will be opened by Professor De Bie, who was also the chair of the assessment committee. He's professor of physiotherapy research at Maastricht University.
Okay, thank you. Dear candidate, congratulations with this achievement. looking at the wonderful work that you did and also the wonderful pictures that are in there. We see it also on the screen. The front is the Stelvio, right? And I immediately had the impression that sailing wasn't your hobby. It's probably something to do with cycling. And this also means that you're a person with a kind of attitude that you can keep on going even when it gets tough, right? Although this is so heavy that I thought, when will it stop? And I understood from Martijn that you even have a hard copy, a very hard copy, which some people have to go to the sports gym to be able to lift that. And I was really worried when I heard that in his version that was part 1. And then you start to think, well, will it ever stop? But congratulations with this wonderful work. In your word of thanks, you also write that you look forward to an advanced and varied discussion with rich interaction. So we'll try to do that. No guarantee, although. Your thesis writes interesting perspectives on hip and knee surgery. Well, a very long time ago, I even taught anatomy, and I still had the idea that the hip and the knee are not completely comparable, and you already gave some ideas of that. And in chapter 4, you actually have a group of people, some 525, you also had some slides on that, and some 440, I think, were available for analysis, and 110 couldn't go the same day home, right, a quarter. And you have discovered a number of factors of influence. One of the funny factors that I thought and was amazing, that weight doesn't really matter, right? But being a female does. As a female, you're really unlucky. You have a 70% more chance of not going home the same day compared to men. And then in the discussion, you have a number of speculations. And please, ladies, it's not meant offensive, but it's in the thesis, right? So women have a lower functional score, probably related to muscle strength. Women are older and have bad functional score because of that preoperatively, and women are more verbal about needing help. So the solution is only operate upon young women who don't complain. Probably that's too easy. So I wonder what your population really looks like. I would have expected something like an age-stratified analysis, because the women are somewhat older, and you have half men, half women. Could you give me some idea what your women really look like? Because I cannot get it from chapter 4, and I would have expected different results for different subpopulations. And for sake of discussion, you can have the unilateral and the full knee together as a group. But could you give me some idea? Because it feels a bit funny, right? Because aren't women, in general, a bit older than the men? And would that not, if you stratify it for age, take away a number of your findings?
Highly esteemed opponent, thank you for your kind words, and also thank you for your question. So it is hard to look at this specific group of patients who include females, because it is also a very pre-selected group of patients. So if you want to tell whether somebody is really at high risk for not going home, you should look at unselected group of patients. For example, all patients coming into your outpatient clinic and you offer them surgery, prospectively follow them and see how these patients compare to each other. For example, males and females. We, with our, like the retrospective cohort study and like the pre-selected group of patients, it's pretty hard to make a definitive conclusion on that. But for example, a research study by Gromov in 2017, they found that in an unselected group of patients, that females in combination with higher age had a higher risk of unsuccessful same-day discharge.
That was what I thought.
Yes.
Right? I wonder a bit about what happened to the almost 80 patients that didn't make it to your cohort. Were the data incomplete, or were there selective factors that you left them out? Because from the 525 you analyzed for 40, right?
Yeah, we analyzed all patients, so we analyzed 525 patients, but of those, 110 were unsuccessful to be discharged on the same day. So we included them in the analysis, and we included them to say something about if we pre-select our patients, is there still, can we still identify factors, even if we think that they are suitable for the outpatient pathway? Are there certain factors that tell you otherwise? That's.
I would have thought that you would have left a number of people out based on a number of clinical criteria. If you expect a bad outcome of the surgery, it's a special case, right? And being able to operate upon someone, they need to be in a certain physical shape or condition to be able to survive the surgery. At least that seems sensible, right? Otherwise you have no patients left in the long run. So, could it be that patients with excessive weight or cardiac problems or whatever are not in your cohort because of logical selection?
Yeah.
And could that not also overestimate your optimistic finding that everyone goes home rather quickly?
That's certainly true. If you look at the numbers for our cohort, for example, only 3 patients with BMI higher than 40 were included. That's not the general arthroplasty population. So our patient selection included like a subset of selection criteria, which also included BMI. Still, some patients with a high BMI got included somehow, but that's mostly because of the discretion of the surgeon. Like if you don't look at the BMI, but somebody thinks he's very fit and very motivated to be discharged on the same day, I don't think it should be like a hard exclusion criteria. But we as a doctor, we should keep it in mind that those patients might be at a higher risk for going home. Same
risk of not going home, I think.
Yeah, not going home. So the same thing is with also we have to look we have to look after the caregiver, right? If somebody has a BMI of 40 plus, and the caregiver is a small male or female, they are not able to care for them or help them with like mobilizing or help them making the transfers.
And one of the things that we always worry about is which patients are at risk of getting a less optimal outcome, right? And you now have a kind of a hard outcome, going home or not going home. Wouldn't you be more interested in going home in an optimal way? Wouldn't it be better for some patients to stay 1 day longer in the hospital because then they get more instruction by the physical therapist or the surgeon, and also have already survived a number of these peaks that you showed in the graph? So is going home, it's an easy outcome, but does it also reflect optimal outcome? That's my final question.
Yeah, it doesn't necessarily define optimal outcome. I agree with you on that. And for instance, you can discuss whether I think, and if you have like all the optimized pathway, and people recover that fast that they're able to go home the same day, we should prepare them for maybe going home the same day, but it doesn't need them to go home the same day. They need to feel confident, and they need to get to a certain amount of discharge criteria. So it's not the outcome should be safely going home, and also feel for them feeling safe to go home. And
Okay, I'm happy with your answers. I give the word back to the prorector.
Thank you, Professor De Bie. The next opponent will be Professor Trulsen, Professor of Clinical Orthopedic Research at Copenhagen University Hospital in Denmark. Thank you for being here, coming all the way to Maastricht. The floor is yours.
Thanks, Prorector, and first of all, many thanks for the invite coming here to my colleagues working here, and it's really been great to study your work. I have spent 16 years in this field, so I'm an arthroplasty surgeon doing primary hips and knees, as you know. So for me, it's been really interesting to see and read your perspectives on this. I think I enjoyed reading it. It's great work, well formulated, great flow. So congrats on that. So I'll just start my clock so that we're not getting overwhelmed by questions here. We have 9 minutes. So first of all, looking back at so using your knowledge and the literature from the past 10, 12 years, what would you say are the biggest game changers in perioperative care? Not out or inpatient, but for perioperative care in optimizing arthroplasty treatment.
Highly esteemed opponent, thank you for your kind words and thank you for your question. So there's numerous of game changers. One of the game changers is working in a team. Like you need to get to your anesthesiologist, you need to get your physical therapist, and everybody needs to be on the same page. We need to optimize care for the patients. It needs to be safer. It needs to be, doesn't necessarily need to be faster, but it needs to be safer. And how we get faster it's like a side effect. Like if you look at the pre-operative characteristics, I think we might be better in setting expectations for the patients, educating them, but still that can be better. Other game changers are using glucocorticosteroids to reduce the surgical stress, like actually reduce the surgical stress response, and make that there's less risk of adverse events or the unwanted sequelae of the stress response, like pain, nausea, the orthostatic hypotension, all these kind of things. Other game changers are the use of TXA, for example, and also the pre-operative optimization of the patients. We pre-operatively check whether somebody has anemia, like a low hemoglobin, and then before that we already try to adjust that. So there's some game changers. For example, the glucocorticosteroids, the tranexaminic acid. But
may I just come back on the glucocorticoids, because I think you were very right about that. So for me, clinically, that was definitely a huge change. So you write in your thesis that you give high dose, and you say 8 milligrams. Is there more literature now to suggest alternative dosing?
Yeah, so there is more literature. Like the cohort runs from 2013 to 2019, and back then we were worried about, or also the anesthesiologists were worried about the hyperglycemia with patients, for example, and diabetics. That's why back then it was a high dose, but nowadays there's a lot of research being done that proposing even higher dose might have more beneficial effects for the patients. There's 2 RCTs. I think the third one is coming up from Denmark, Copenhagen, and one of the RCTs does compare patients who have a high dose, 1 milligram per kilogram. That's if you have a patient of 70 kilos, that would suggest a 70 milligram glucocorticosteroid.
Yeah, that can certainly start a party, I can tell you. So I know this. So just because I have a lot of things, dear candidate. So so in Holland you're using more and more unicompartmental knees, I guess. How does that lean itself to the stuff you're talking about here?
So I think there's a big the unis if you look at the data, I think only 150 were uni and 250 were total knee replacement. But unis are less invasive for the patient, less bony resection, less soft tissue trauma, and that makes that patients usually recover faster, have less pain, and have higher PROMs, patient-reported outcome measurements. If we look at the Dutch practice, I don't think we're quite there yet. If you compare it to other countries, I know for a fact that in some countries the utilization rate is up to 50%, and if you look at the data from the Oxford Clinic, it's also better to do a uni compared to a total knee and really look for the rare patterns in those patients, because we probably miss them. And that's maybe due to there's three groups of surgeons: the ones who do total knee arthroplasty, but also the ones who don't do it. And there's the ones who make use of a lot of contraindications, whereas in fact they are not contraindications.
Mr. Kennedy, now we're talking about a very, very nice subject. I love it, but we have to move on into the outpatient care. So chapter 7. You seem to be slightly disappointed about your findings or lack of differences. Was it disappointing to you to put this together?
So that's a chapter where we compared the inpatient and the outpatient pathways. I don't think it's a disappointment. It rather shows you that we are doing good in the Netherlands. The pathways are more or less comparable, and all those hospitals who don't implement the fast track, like the same day surgery protocols, they might with a few twitches in their protocol, or maybe even just optimizing logistics and putting in the selection criteria, might even help you to get to it. But so I was not really disappointed. It was more or less that we're on the right track, and maybe just few differences could be made to have a higher utilization rate.
And in your search for differences, you make a lot of comparisons in that chapter, in that study. Do you have kids?
I do have 2.
Yeah. So if they ask you, "Can I have candy, Dad?" What do you say usually?
So this morning I said yes because I was really rushed. But
any other day you would say no, right?
Yes.
If they ask 45 times, "Can I have candy, Dad?" Do you think you're more likely to say, just out of coincidence, you're more likely to say yes?
Yes.
Yes. Okay. So you have 45 p-values in that study. Is that a problem?
I think yes.
Yes, okay. Good answer. Anyway, I think you could not have done it very differently, but there are methodology whereby you can adjust for things, and you can maybe also ask yourself, what are the more important questions to really compare here? I think that was the point to make on that. Anyway, you find a difference on tranexamic acid, on early mobilization, hemoglobin check. Not very big differences, and it will lead me towards my final question. So what would you actually have? Would you stay in hospital, or would you rather go home on the same day based on all your knowledge here? And you can imagine it's one of your parents having the treatment. What would they have and why?
Yeah. So personally, it really depends on what stage you're in, like mental state, but also
they are eligible. Let's say they are eligible for both in and outpatient.
Yeah, I would go home.
Okay.
Yeah, because if the post-operative care is well aligned and well organized, I don't think there's a higher risk for not going for going home the same day.
Could it be that the surgeons running outpatient are simply better at saying go home? Because it doesn't seem that there's a lot of differences in the two care pathways. So is it more about, you talked about teamwork, you talked about how you manage patients when they are in setting expectations. So could it be that the secret sauce is just to being better at saying, go home?
Maybe that's the case, but I think there's more like barriers for us to overcome, and in order to get like a wider implementation of the pathway and sending patients home the same day, you need like maybe financial incentive, and don't be punished for sending the patient home. So that's one thing, but also the logistics of a pathway. Like we need to like have shared goals and get everyone aligned. And I think in those pathways, with all the physical therapists, the nurses, anesthesiologists, they try to arrange everything as smooth as possible for the patient in order for them to go home. So I think it's a mindset that really helps. And maybe we say it quicker or easier to our patients, but that's also because we think it's safe and we did our research on it.
Thank you very much. Pro-Rector, please.
Thank you, Professor Trulsen. The opposition will be continued by Professor Groot, Professor of Health Economics at Maastricht University.
Thank you, Mrs. Pro-Rector. Dear candidate, let me start by expressing my appreciation for the work that you have done and congratulate you with your achievement. I think your work contributes to our evidence and knowledge about the potential of outpatient orthopedic surgery. But not only that, it also has an important social contribution to make. I think everyone either has had experience with orthopedic surgery, him or herself, or knows someone in his immediate surroundings who has had orthopedic surgery. And for them, I think your findings on the potential of outpatient orthopedic surgery is very valuable. I think the social relevance of your study is also that it shows what the potential cost savings are of outpatient orthopedic surgery, and that's an area where I have some that enters into my area of expertise, and that's also an area I want to engage in a discussion with you. In Chapter 2, in your review study, you'll find that on average, outpatient treatment leads to a cost saving of a little less than $6,800. Which is approximately 5,800 euros. You also find there's a huge variation in the cost savings found in the studies that you review. But not only that, 6 out of 7 of these studies are studies for the US. And that raises the question whether this cost saving also holds for the Netherlands. Would you expect that the cost savings would be equal or higher or lower than those found in the literature for the US? That's the first question I want to ask. Secondly, you also find that patients who received outpatient treatment are on average younger, more healthier, lower BMI, lower ASA score. So that raises the question to what extent this cost savings can be attributed to the fact that these are lower cost patients, or whether it's really an effect of the outpatient treatment that they receive.
Highly esteemed opponents, thank you for your kind words and thank you for your question. With regard to your first question, I would think that the overall cost savings in the Netherlands would be lower. And that's because we are already quite fast in our pathways. If we look at Chapter 7, the average length of stay is 2 days. And by reducing it to going home the same day, like the delta is very small. So that's one. And two is that the health cost in the US is usually higher. And that translates to the high cost savings they probably found in their study. So I know there is some cost-effectiveness studies in Europe. I think there's one in Denmark, and that found that the cost savings will be more or less like 1,000 to 2,000, translated to dollars. Another study recently done, I think it was published in 2022 in Canada, that was a RCT, and they also compared inpatients with outpatients, but they looked at the societal perspective for cost effectiveness. And in total, they found from a healthcare perspective that only $750 were saved, and from the societal perspective, about $1,250 were saved, which makes a total of also 2,000. So it makes it very hard to interpret these results because they're all from the US, and the US healthcare system is very different from what we are used to in the Netherlands.
Yeah. I would expect it that the costs are lower here in the Netherlands than in the US. On the other hand, for outpatient treatment, there are also other costs involved. What was already evident from the discussion that you had with Professor De Bie. There may be costs because of the informal caregivers who have to take time off from work, for example, children, partners. To provide more care for patients. If you add these in, do you still expect to be that outpatient treatment would have a net cost saving?
Yeah, I think that's a valid concern. However, that same study I was referring to, the study by Zomar from Canada, so they also did that. So they asked patients, but also their caregivers, to fill out questionnaires about the cost they made in the postoperative phase. And even when they accounted for that, they found that outpatient surgery was cheaper. It saves money. Yeah. I don't have a good explanation for that.
Okay. My final question would be, is the data that you present in your dissertation are collected in the top clinical hospital, as they said, hospital. And what rather surprised me is that if you look at the patients, that around half of the patients, a little less than half of the patients, are ASA1 patients. And you wonder whether these patients could not be cheaper be treated in, for example, private clinics or not in top clinical hospitals. What would do you agree with that? Isn't it then more efficient that we channel these patients to other clinics rather than to clinical hospitals?
So from a societal perspective, it makes sense to maybe shift some care to other institutions, but that doesn't necessarily have to be the ASCs or the ZBCs as you're referring to. We can also increase our efficiency within the top clinical hospitals by creating focus clinics. And I think there's a lot of room to make it more efficient, even in a top clinical environment, to reduce the overhead costs, even there, because that's a big problem. Okay. The overhead costs are higher.
I'm satisfied by your answer. The pro-rector indicated that she wants to proceed. Let me finish by saying that your hospital, Zuiderland Hospital, of course, has plans to develop a focus clinic in Heerlen.
Thank you, Professor Groot. The opposition will be continued by Professor van Zundert, Professor of Pain Medicine at Maastricht University.
Thank you, Pro-Rector. And also from my side, felicitations for you and your promotion team for the very, very nice work and layout. But we are advancing in our time, so we'll go a little bit into the discussion. And I was interested in chapter 8, a qualitative study, which is not a standard study design, and especially not for an orthopedic surgeon, I suppose. So what were your experience? Why did you come to a qualitative study? Can you explain us?
So why we did a qualitative study is to see how the patients really think about it, but also the caregivers. If you look at the standard orthopedic study, we always have the same outcome measurements. And those are PROMs, patient-related outcome measures, and they're usually measured preoperatively 6 weeks after surgery, 3 months after surgery, and a year after surgery. But that doesn't capture how the patient really feels when they're at home, and also how they experience the pathway. So, in order to really think, we think it's safe, but how that
we know about qualitative study. But how was your experience as an orthopedic surgeon? Because it's another mindset.
So, how my experience was with I think it was nice, like the study, but.
The goal of a qualitative study is to give a qualitative evaluation of the patient experience. And then I read on page 246, the results, 92% of satisfaction, which is quite quantitative.
Yes.
Is that then the goal, starting with a qualitative study and coming with a quantitative outcome?
Yeah, that's a valid point. So it's what we try to do in the study is to report all the qualitative findings in the results by coding the patients. However, we as an orthopedic surgeon, but also the reviewers, they like numbers. And it was kind of hard to otherwise enthusiast, how do you say it? Enthusiast as other people about your study.
Nice to hear, because it brings me to my next point. Was it easy to publish a qualitative study?
Short answer, no. It was not easy to publish. No.
Yeah. I am also a promoter of PG students. I also try to get qualitative studies published, and I have the same experience. So you finally end up this year with a publication in Curious, I saw. How did you select that journal? Are they specific for qualitative studies, or was it that you tried it several times at other journals and then ended up with the open access journal, or?
So we tried the usual suspects, bone and joint, Acta Orthopedica, etc. But they were not willing to publish it. They thought it was well written, and they liked that we looked from a different perspective. But as we discussed before, it's not what they're used to in reviewing. And in the end, we came across an open access journal, and several of my colleagues had a good experience with it. So that's why we tried a shot.
Yeah. I have the same experience. So still work in progress in the academic and the publishing world, I think, because it's an additional value in doing research, but it keeps some time. I'd like to go to the next point, and of course you have propositions in the thesis, so I invite you, one of your paranif, to read proposition or statement 2, number 2.
Outpatient hip and knee arthroplasty is feasible and safe. However, its success depends on strict patient selection and well-structured care pathways, as not all patients are suitable for this approach.
Thank you very much. I'm always triggered in words like safety, in statements, propositions, conclusions of articles, this kind. When can you say that a new, still a bit controversial technique is safe? What are your criteria to say that?
That's a good question. I think you can look at it from different perspectives. It can be safe from a healthcare perspective if complications, readmissions, and those outcome measures are not increased.
Okay, but how many patients do you need? How many studies do you need? How many? When can we say it's not anymore an experimental technique? We can go to routine clinical practice.
Yeah, I mean, you would for sure need like high quality studies to be done, and that's the main issue in the beginning with the outpatient. It was only done in highly experienced settings with highly experienced surgeons. So they had a lot of experience, and they published great results. But nowadays there's 2 RCTs who publish the same. So the tendency who publish the same, that those outcome measures are not increased.
Okay, 2 RCTs, and one is yours, I suppose. Or so, how many patients were included in those RCTs? Do you have an idea?
Sorry?
How many patients in total were included in the 2 RCTs?
It was a tendency around 50. I think in one study it was 45. No, I think
complications rate are quite low.
It's rather low, yeah.
So an RCT is not a good way to evaluate the safety. Therefore, you need long-term experience and long-term follow-up. So it's a classical issue that young researchers try to say something is safe before we have enough data to really say that, because it's an important statement. For patients, it's the most important. Is the new technique safe, yes or not? I still have one neighbor, to go, so I will not use all your time. Small question about chapter 4, the predictors. And on page 112, I read in the bivariate analysis, which is of course the topic on itself, that WOMAC scores, VAS pain scores, and ASAA classifications were significant, different, or important for the predictions. So those are all related to anesthesia and pain. So what are your conclusions for daily practice on this outcome?
So there is a tendency that patients who are doing less before surgery, whether that's a very low functional score or whether there's a lot of preoperative pain, they have a tendency of doing worse postoperatively compared to the patients who don't have the preoperative pain.
So you took this analysis into your daily decision, which patient you go for, an outpatient or inpatient?
Yes, we don't include, or we are like hesitant to include patients that have like chronic sensitization issues of chronic disorders, but also like chronic opioid use. So we are more hesitant to include those patients in the pathway.
Thank you very much. Thank you for your answers. Keep on going on the road and on the research. And I give the word back to the prorector.
Thank you, Professor van Zundert. We come to the last opponent, Dr. Bolink, orthopedic surgeon at Deventer Hospital. And thank you for being here in Maastricht.
Thank you, Prorector. Thanks for inviting me. Thank you, Professor van Zundert, for saving some time for me. Dear candidate, I would like to congratulate you on this great achievement. I would also like to congratulate your team of promoters. And I think it takes a lot of determination to finish such a nice thesis, especially when you're doing it during your training program. And with all this, also taking your responsibilities as a young father and a husband. So well done. With much joy, I have read your thesis, and I would like to question you in a few topics. But first, I would like to ask your other paranymph to read statement number 5.
With an aging population, orthopedic care must move beyond treatment to emphasize prevention and maintenance of mobility.
Thank you. To emphasize prevention. Then please, Mrs. Leenders, could you read statement number 7?
The word is sharper than a surgeon's knife.
Thank you. Okay, so we should focus on prevention and we should rather use the word than the knife. So that makes me doubt that should we then in your training program focus more on prevention and communication skills, or should we teach you how to perform surgery?
Esteemed opponent, thank you for your kind words. Also, thank you for your question. I think both are true. We need highly experienced and good orthopedic surgeons in order to provide high quality care. But we also need to be careful with indications. We should rather also look for prevention to keep our population on the move. And keep them fit. We should look for metabolic disease in those patients and also treat that before we always take the knife. One of the things when we look at optimization of care pathways, now we look at the crown of optimization, outpatient joint replacement, but there's much more than that. There's a lot of patients who are not feasible for this approach, and those patients they might stay like 5 days in the hospital, 6 days in the hospital, and even after a year they're not satisfied with the results, and that makes there's a lot more research to be done. First of all, for getting those patients to recover quickly, and second, that we need the right indication for the surgery. And sometimes we might be tempted by our patients if they come back for the 10th time to finally grab the knife. And that's
all right, thank you. Well, I'm not sure if my residents at Deventer Hospital will be happy with that answer, but I will continue. So we are lacking a bit of time, so let's go straight to the thing I find most interesting, which are the hips. Surprisingly, in your cohort of 525 patients, only 90 patients were total hip arthroplasties. Why was that?
I don't have a good explanation for that. Maybe the patients were less likely to engage in a certain outpatient pathway, but that cannot be substantiated with the literature, because if you look at the literature, there's a study published that patients with a uni knee but also a total hip were more likely to want it in the future compared to the total knee. So I don't have a good explanation why we have a very high total knee group and a relatively low total hip replacement group. Because if you look at the questionnaire we did, also the orthopedic surgeons who we asked, they thought that the total hip arthroplasty was perfect for outpatient setting.
Exactly, I think the same. Then during this retrospective review in 2017, which is near the end of the period of this inclusion, the anterior approach was introduced by 2 of 5 surgeons. Mm-hmm. So do you know how many patients in your cohort of 90 hip arthroplasties were actually treated by the anterior approach?
I would have to make a guess. I'm not sure whether it's in the table. I think it should be in the table now.
I couldn't find it. So.
Yeah. Then I don't know how many it were.
That's fine. So
it would be more likely to be because in the group of 90 hips, maybe 10 or 20.
Yeah,
maybe.
I was guessing the same, between 10 and 20. But then you have done some comparisons with the success rate of the same-day discharge, and you say that for the anterior approach it was 82%. And for the posterolateral approach was 77%. Mm-hmm. But because probably these numbers are very small, mm-hmm. this difference of 6% was not significant. But do you think that if we would have a larger cohort, or let's say we multiply these numbers by 10, and we would do the same comparison, do you think this would be a significant difference?
Yeah, the anterior approach tends to be like less soft tissue damage, so muscle sparing, how it's called. But I'm not sure whether that's the where we should look at. We always try to improve and optimize recovery by our own tricks, like minimal invasive, anterior approach. I personally think it's way more important to look at the surgical stress response, like we discussed with Professor Trolsen, and how we can optimize it for all patients with glucocorticosteroids, etc.
Mark Keulen, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room. Mark Keulen, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Heiligers is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor. All right, please.
Thank you very much. Dear Mark, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
I promise.
By the authority visited in us by law and in conformity by the decision of the committee here present, I hereby confirm upon you, Mark Hendrik Franciscus Keulen, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the University of Maastricht. Before I give the microphone to co-supervisor Dr. Schotanus, I will give you this small statue by the School of Health Professional Education where you got your PhD. You see it's an orthopedic staircase without handheld. So you need someone to help you upstairs. And halfway you see the booklet, that's your PhD. It means that we hope that you continue doing research after you finish the whole staircase. And when you're up, you go down to help other people to go up again. So congratulations, and I give you this statue by Xi.
Thank you.
It's my great honor and pleasure to deliver this laudatio on behalf of Ida and Bert. Most esteemed Dr. Keulen, dear Mark, what an achievement. Today we celebrate not just your dissertation, but years of dedication, ambition and character. Your research on outpatient arthroplasty is more than a dissertation. It's a standard work, a carefully prepared guide, maybe even a small masterpiece. And knowing you, you probably will have added a few more chapters because of your goal was nothing less than the gold standard. Anyone who knows you knows that setting the bar high is never enough for you. You always raise even it higher. And how you do that, again and again, it's truly admirable and a little mysterious. Your dissertation shows it perfectly, structured, precise, and with a typical Mark touch, a hint of confidence that drives your success. And that's why it was very frustrating for you when the printer company didn't quite meet your standards. In fact, you almost started printing it all yourself at home. But we were impressed with the result, though we also felt a little sympathy for the reading committee. Thank you for that. For you, completing a PhD was like top-level road cycling, every stage uphill, giving it your all, and always reaching the summit. Luckily, you had a strong support team at home, Kirsten, Otis, and the recent bird of Lauren, and of course Seb. Seb is the fourth-legged friend of Mark, who keeps his mind overflowing, excuse me. Kirsten, thank you for keeping Mark grounded. He really needs it. Besides your dissertation, you're nearly finished your medical training, started a family, and inspired countless colleagues and students. It's like climbing a mountain, performing surgery, and publishing a paper. A typical week for Mark. How you manage it all, we don't know, but you do it. You combine precision, professionalism with humor and warmth. You're a dedicated doctor, a sharp researcher, a great colleague and friend. But let's be honest, sometimes also a truly absent-minded professor. The man who looks for his phone while holding it in his hand. Sorry. Or who not only wants to improve clinical care paths, but also wonders how he could literally cycle them. Mark, today you stand on another peak. A peak that symbolizes knowledge, dedication, and character. And knowing you, we suspect you're already thinking about the next climb. Enjoy this view, Mark. Wish you and your family happiness and good health. Thank you for your tireless dedication and all the best for the future. Thank you.
Dr. Keulen, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. I also congratulate your family, friends, colleagues who somehow have supported you during this PhD trajectory. I'd like to congratulate your supervisors, Professor Heiligers, Dr. Bode, and Dr. Schotanus. I'd like to thank the members of the degree committee for their presence here, for the time they have invested in preparing for this degree defense, I would say. Especially I'd like to thank Professor Trulsen and Dr. Boling for coming to Maastricht, extra time, but it's very much appreciated by Maastricht University. I was really intrigued by the backside of your PhD book with a small cyclist, but now seeing your son, I think I understand that you have plans to cycle with him up the Stelvia in the future.
Maybe. But that's actually him on the back of the... Yeah.
Well, that's a faraway goal. I hope your goals for the near future are more clear, and I wish you a lot of success in finalizing your training and with your further research, which I hope you will continue. And with this, I close this academic ceremony.
This me?